welcome back to the channel. Today's topic of discussion is ischemic heart disease. What is ischemic heart disease? It is the imbalance between oxygen supply and demand in the cardiac muscle. The primary cause is atherosclerosis, where plaques build up in the coronary artery. In the picture, we see the lumen of the coronary artery, where the yellow color lipid core is covered by the inner fibrous cap. The fibrous cap covering the lipid core approaching towards the lumen of the coronary artery, causing gradual obstruction. Key risk factor: dyslipidemia, especially elevated LDL, hypertension, diabetes mellitus, smoking, obesity and metabolic syndrome, family history and genetic predisposition. Pathophysiology: oxygen supply versus demand. Oxygen demand increases with the heart rate, contractility, and wall stress. Coronary perfusion occurs mainly during diastole. As tachycardia shortens the diastole, it reduces perfusion. Coronary resistance is regulated at the three level: epicardial artery, large vessel, prearterial, transitional vessel, and arterial, that is microvasculature. Atherosclerosis impairs vasodilation, thus increases resistance. Plaque formation and acute events: endothelial injury triggers lipid infiltration in the subintimal level, causing macrophage activation and foam cell formation. Plaque may remain stable or become vulnerable. Thin fibrous cap and large lipid core are prone to rupture. Rupture exposes thrombogenic material present in the plaque, leading to platelet aggregation and thrombus formation. Acute coronary syndrome results for sudden plaque erosion or rupture, causing partial or complete vessel occlusion. Ischemic effects over myocardium: transient ischemia causes reversible dysfunction, but when it is prolonged, say more than 20 minutes, leads to infarction. Functional consequences: regional wall motion abnormalities, reduced ejection fraction, diastolic dysfunction, electrical instability like arrhythmia and conduction block. ECG finding: HT segment changes, may be depression or elevation, T wave inversion, pathologic Q wave infarction. Here we see three ECG waves. The first one, the ST segment depression, but it is upsloping. The second one is the downsloping ST segment depression. The third one is the horizontal ST segment depression. The first one, the upsloping ST depression, is not so significant for ischemic heart disease, but the downsloping and horizontal depression are characteristic for ischemic heart disease. We also know that 1 millimeter ST depression for at least 2 millimeter horizontally is significant. Clinical presentation: under clinical presentation, there are four broad headings: stable angina, unstable angina, atypical symptom, and silent ischemia. Stable angina: there is chest pain and discomfort with exertion relieved by rest or nitrate. Unstable angina: new or worsening chest pain or rest pain as a part of ACS. Atypical symptom: where no chest pain but there may be dyspnea or fatigue or epigastric discomfort, more common in the elderly, women, and diabetics. Silent ischemia: no symptom despite ECG or imaging evidence, common in diabetics due to autonomic neuropathy. Diagnostic workup: initial evaluation by history and physical examination, ECG, cardiac biomarker like TROP, TCP-KMB, blood test, lipid profile, HbA1c, C-reactive protein, and CBC. Functional testing: exercise ECG, stress test, stress echocardiography, or nuclear perfusion imaging. Anatomical imaging: coronary CT angiography for non-invasive, invasive coronary angiography for definitive diagnosis and intervention planning. Management: lifestyle modification, Mediterranean or DASH diet, regular aerobic exercise, smoking cessation, weight reduction, and glycemic control. Regarding pharmacologic therapy: anti-anginal like nitrate, beta blocker, calcium channel blocker, antiplatelet like aspirin and clopidogrel like drugs, lipid lowering agents, statin, ezetimibe, ACE inhibitor or ARB for hypertension and LV dysfunction, ranolazine and nicorandil for refractory angina. Revascularization: PCI or percutaneous coronary intervention, balloon angioplasty with stent, preferred for single or two vessel disease. Coronary artery bypass grafting, that is CABG, it is indicated for the left for main artery disease or triple vessel disease or diabetics, where surgical grafting is done using internal mammary artery or saphenous vein. Prognosis and follow-up. Prognosis depends upon extent of the coronary disease, LV ejection fraction, presence of diabetes or renal dysfunction. High risk feature: poor exercise tolerance, extensive ischemia on imaging, recurrent angina or arrhythmia. Secondary prevention using statin, antiplatelet, proper control of blood pressure and glucose. Thank you.